Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our panel of experts. Well, 1 in 3 women will experience a pelvic floor disorder in her lifetime. Pelvic floor disorders occur when women have weakened pelvic muscles or tears in the connective tissue, which may cause bladder control problems, bowel control problems, or surrounding pelvic organs to fall into the vagina, causing pelvic organ prolapse. Jefferson Health's comprehensive female pelvic medicine and reconstructive surgery multidisciplinary team specialize in the diagnosis, management, and treatment of PFDs, from conventional to complementary medicine. Well, thank you so much for your questions in advance of tonight's webinar. The questions that you'll hear me asking the panelists are all submitted right from when you registered for this webinar, so thank you. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A, and you can go ahead and submit your question right there. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during tonight's virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Okay, well, without further ado, let's go ahead and introduce our urogynecology experts for the evening. And I will let each one of you go ahead and just say a few things about yourself. So let's go ahead and start with Dr. Carolyn Eccles. How are you doing this evening?
Hi, good evening. Welcome to the webinar. My name is Carolyn Eccles. I am Section Chief of Female Pelvic Medicine and Reconstructive Surgery, otherwise known as urogynecology, which is going to be the new name, at Jefferson and Center City. I specialize more so in some complementary alternative approaches, since I had done an integrative medicine fellowship and do a little bit of acupuncture as well. But I also do bread and butter urogynecology, more so the vaginal approaches as far as non-surgical, and then of course the vaginal approaches for surgical options for prolapse and incontinence. And I do a little bit of laparoscopy. So welcome.
Yes, welcome. We're excited to have you. Thank you. All right. Next up, we will introduce Dr. Whitney Smith. Welcome, Dr. Smith. We're excited to have you.
Thank you, everyone. Thank you for having me. My name is Dr. Whitney Smith. I'm also another urogynecologist in the Jefferson network. I primarily see patients at Abington location, and I also see patients in South Philly at the Navy Yard. I am a little bit of a, I've been with Jefferson for quite some time. I started as a urogynecologist here in 2021. However, I did do my urology training here for 6 years prior to that, and then moved on to do my fellowship training in Winston-Salem, North Carolina at Wake Forest. My specialties, I also do reconstructive surgery, including laparoscopy, robotics, as well as vaginal surgeries. And I also treat urinary incontinence and complex voiding dysfunction. So I'm really happy to be here. Thank you for having me.
Yes, thank you for the introduction. Okay, next up, Dr. Renita Ross. Welcome. How are you doing this evening?
Thank you. Thank you. I'm well. Thank you all for joining us. We are all very privileged to be able to address women who have pelvic floor issues. I am a urogynecologist, and I've been with Jefferson approximately 4 years. I previously did much prolapse repair and and now my focus is on incontinence, urinary incontinence. I also have a focus on pelvic pain with intercourse, pain that prolapse can bring, with bladder issues, bladder pain, and sexual health. So I feel that all of these issues, including prolapse and incontinence, are extremely important for women. And we're very happy to be able to hopefully give you some answers and provide future care if needed. Thank you.
Thank you, and we're happy to have you. Okay, and finally, Dr. Urini Quesada, welcome.
Hi, thank you so much. It's a pleasure to be here. My name is Irini Quesada, and I am the Division Chief for Female Pelvic Medicine and Reconstructive Surgery over at Albert Einstein. I see patients down in the Philadelphia area at Einstein, as well as the Montgomery Blue Bell region. I primarily manage patients with both urinary and fecal incontinence, pelvic organ prolapse, any lower urinary tract syndromes, and I also perform reconstructive surgery, as well as deal with sort of anomalies which patients may be born with or develop in the form of fistulas, which are usually abnormal communications between either the bladder and the vagina or the rectum and the vagina.
Okay, well, thank you all. And I know I'm looking forward to our discussion. So without further ado, let's go ahead and dive into tonight's questions. So for question number 1, Dr. Smith, we'll go ahead and start with you. So is there anything non-surgical that can be done if one has a moderate prolapse and incontinence?
Yes, it's a very good question and one that we get asked quite frequently. And the answer is yes, there are several different options, and pelvic floor disorders are very common, and we'll kind of go through each one in general categories. So firstly, with these pelvic floor disorders, although they can be very bothersome, can have a huge impact on one's quality of life. These are not life-threatening conditions. So a perfectly viable option after you meet with your urogynecologist, if you choose to decide that since it's not that bothersome to you or it's not impacting your quality of life significantly, observation or watchful waiting is appropriate treatment to not choose to pursue any treatment at that time. So when it comes to all of these conditions as well, we also work with experts, pelvic floor physical therapists, who can help to treat all of these disorders without surgery. Just kind of a side note, we are some of the urogynecologists in our division. However, we also collaborate with others as well, including pelvic floor physical therapists, colorectal surgeons, minimally invasive gynecologists. So we're a part of a whole collaborative effort. So sometimes we do have patients seek referrals with some of our colleagues to help manage conditions. So back to prolapse. When it comes to prolapse, there is an option to have a vaginal insert device, such as a pessary. It's a rubber insert. It looks like a little disc, and they come in different shapes and sizes to be kind of modified to the patient's needs and also the patient's degree of prolapse. And we do stage prolapse on a scale to 1 to 4, with 4 being the most severe. So different shapes, sizes may need to be tried, but that is a non-surgical way to manage prolapse. In addition, there's some lifestyle modifications as well, like avoiding weight loss and avoiding heavy lifting if one can. Those things can also help with the symptoms of a prolapse, which can be kind of a heavy feeling in the vaginal area, maybe some low back pain and feeling like a bulge, like a ball or something is falling out of the vagina. Working with a pelvic floor physical therapist, they can also identify any associated conditions such as high tone pelvic floor or pain during intercourse, things like that they can work on that can also help with the symptoms of pelvic organ prolapse. So now urinary incontinence, there's 2 general categories one is called stress incontinence, which is leakage of urine with laughing, coughing, sneezing, maybe physical activity like jumping on a trampoline. And then there's urgency urinary incontinence, where you get that all of a sudden gotta go, and may leak because you can't get to the bathroom in time. And working with a pelvic floor physical therapist or getting some advice on pelvic floor exercises from your urogynecologist can help with strengthening your pelvic floor muscles. They can also help with bladder retraining and using those pelvic floor muscles to suppress urinary urges. And then things like dietary modification to avoid those dietary irritants, such as caffeinated beverages, carbonated beverages, alcohol, sometimes spicy foods that can sometimes trigger or exacerbate the urinary incontinence, and also fluid management. when it comes to fecal incontinence, working with your urogynecologist to kind of identify your stool pattern, see if there's any abnormal stool consistency, doing a pelvic floor exam to identify if there's, if there's any structural abnormalities. So things like dietary modification can sometimes be helpful. Increasing one's fiber to bulk up the stool. There's even vaginal insert devices. We're not quite using them here yet, that can help with fecal incontinence, are non-surgical options to manage fecal incontinence. So there's a variety of things, and sometimes multiple treatments may need to be tried before you can get to one that can work. So very long answer, but there's many options.
Well, we appreciate you walking us through that. So thank you. Okay, so we will continue to our next question. Dr. Eccles, along those same lines, how effective is surgery versus other methods?
So surgery is sort of a set it and forget it type of treatment. And so, after the procedure, approximately 80 to 90 out of 100 patients or women no longer will have these problems. And, if the pelvic organ prolapse is severe, where it's affecting your quality of life or even giving you some issues that can medically be a problem, then surgery is definitely an option, and it can improve prolapse related problems, but it's also associated with some risks. So the affected area, can be accessed in different ways. It's usually possible to do surgery through either small cuts in the abdominal wall, like endoscopy, laparoscopy, or robotically, or through the vagina. And, these approaches are less invasive. It's kind of rare that we actually make a large incision on the abdomen, but there are some cases that it needs to be done. So you think of the vagina as a room, the ceiling is the bladder, the floor is the rectum, the back wall could either be your uterus and cervix, or if you've had a hysterectomy, then it's the vagina. And you can fix the ceiling through something called like an anterior repair, anterior colporrhaphy, or vaginal paravaginal repair. And these are just some medical terms. But basically, the bladder has slipped down, is pushing against the front wall, the ceiling of the vagina, and that's the bulge that you see. You can also have the same thing happen to the floor or the rectum. And you could do the same thing as far as fixing the rectum with a posterior repair, or it's called a posterior colporrhaphy. Now, when it comes to the back wall, and that's also called the apex, there are several options. One, which is the most successful out there, although as you get further out, it kind of can be equivocal to some of the other procedures out there, but it's called a sacrocolpopexy or even a sacrohysteropexy. And basically what that is, it corrects that prolapse that's the back wall of the vagina, and it suspends it to the top of the vagina and the sacrum or coccyx, or your backbone. Now, the way you could do this vaginally is there's a ligament called the sacrospinous ligament, which is a ligament that's kind of underneath the vagina. Also, the uterosacral ligaments, which hold up the uterus, and you can use those to suspend the back wall. Now, the most effective procedure, unfortunately, can't be done in everyone because it's obliterative. The success rates are extremely high, over 95%, but it is an option for those who either do not desire any, vaginal intercourse, or their medical problems are so severe that really this is the easier procedure to do. And it can be done under local. Now, as far as incontinence, and Dr. Smith so graciously, defines stress incontinence and urge incontinence. Stress incontinence, essentially, what happens is there's a vaginal approach, and then you can actually go abdominally or endoscopically using cameras. And so you have the most successful, which is a midurethral sling, which is kind of a support underneath the tube coming from your bladder, so that when you cough or bear down, it gets pressed up against that tube. And the success rates are over 85%, some in the 90% range. Then you have kind of a bladder neck sling, which can use your own tissues. The morbidity of the procedure is a little bit higher, but there's some kind of stigma when it comes to mesh, although the research on mesh slings are actually really, really promising and successful. But using your own tissues can also help, and that can be performed as well. And then you have salvage procedures such as a bulking procedures, which you can use calcium crystals, hyaluronic acid. These are all biodegradable, and some of the newer things like PRP and fat. And then some of the more permanent are the polymers that have just kind of come out. And those success rates are more around the 70% range, and some of these patients have to get re-injected. Now, when it comes to the abdominal approaches, or even robotically or endoscopically, laparoscopy, that's using sutures to kind of support the urethra. It's either called a Birch procedure, which it's kind of coming back into favor some patients, where you suspend the tissue surrounding the urethra to kind of a ligament over a bone by the groin. And then you have what's called a Marshall-Marchetti Krantz, which we don't really do too much anymore, but it may be a salvage if you cannot find that ligament, and that's suspending it to the pubic symphysis. So, there's some options out there, and the risks, there are some risks out there for the surgery, but not as much as people think there are. And in good hands, most people do very well.
Okay. Thank you. And thank you for talking through those options there. All right, moving along. Dr. Quesada, at what point should someone have prolapse surgery? And is there a certain criteria for the surgery?
Yeah, so I think that Dr. Smith sort of spoke very eloquently about the different types of options for pelvic organ prolapse. But just to recap, conservative management, pelvic floor physical therapy, the utilization of a pessary or the vaginal insert, or having surgery for pelvic organ prolapse. I think that if patients have either exhausted all of their options or they're no longer a candidate, then they can actually consider having surgery. There are patients that are not candidates for any of those options, and therefore they move on straight to surgery. There's also patients that may develop renal dysfunction where their kidneys are starting to be affected by the advanced stage prolapse. So there's 4 stages of prolapse, 1 being the least, 4 being the most advanced. In stage 4 prolapse, there's a small percentage of patients that do develop renal dysfunction. And in those patients, we do, recommend for some form of management, either with a pessary or surgical management to help minimize the progression of that. And some patients either opt not to go with the pessary, or they've tried a pessary and it's uncomfortable, and then they move on to surgery.
Okay, thank you. And are there any long-term side effects or, other potential complications after reconstructive surgery?
So with any surgery, there are anesthesia risks and there's also surgical risk. And as your surgeon, I usually go over the surgical risk with you. Surgical risk being there's a risk of infection, for which we provide patients with antibiotic preoperatively to minimize that risk. There's a risk of bleeding, which we optimize the patients preoperatively by ensuring that they are off medications that may, potentiate that from occurring. And then there's a risk of injuring any of the nearby organs, and the nearby organs in the pelvis as we're doing these reconstructive surgeries include the bladder, which sort of sits right above, as Dr. Eccles was explaining, as the roof, the rectum, which sits right below the vagina, any of the blood vessels on the side. And there are these 2 little tubes that connect the kidneys down to the bladder called the ureters. So there's always a risk of injuring those, but that said, this is the bread and butter of our practice with pelvic floor reconstructive surgeons. We do have to make you aware of the associated complications, but obviously in our hands, we would minimize that risk.
Absolutely. Okay, well, thank you. Dr. Ross, we will turn to you now for our next question. If a woman develops urinary incontinence later in life, can it be related to an event that perhaps occurred in childbirth?
In short, yes, it can be in relation to childbirth. Just for background a little bit, there are so many aspects of urinary incontinence and involving the pelvic floor. We have to first think about the urethra itself, where the urine comes out, and the bladder. There are support tissues that hold up the bladder and urethra and keep them in place so that they can function normally, that you don't have an incontinence mechanism. There are nerves that innervate the bladder and its contractility, and you're emptying and holding onto urine. There are also muscles involved in the pelvic floor as well. So when we consider all of these things, we know that they can be impacted by childbirth. For instance, if you think about it, the vagina sort of pre and post this pregnancy is just a very sort of small organ. And when you think about that head coming through, how things can get so big, and just think about a head and the shoulders that come through. The result of that can cause injury to the nerves of the pelvic floor, to the muscles, and sort of tearing or causing harm to those muscles, and also to the support tissue. So tearing or decreasing the strength or having weakness in those structures. So all of those things play a role. And if a person has a child, there is an increased risk of incontinence. If you've had no children, there's about a 6% chance. If you've had one child, it goes to about 10%. Two babies, 16%. And then about 3 big births or more, it can be over 25% of people with these with this number of pregnancies can have issues with incontinence. So childbirth definitely plays a role. However, we don't necessarily see that at age 20 or at age 25. Those effects may not show up for a while, but over time, sort of with gravity, with heavy lifting, with constipation, straining with stool, and again, just to even think about it, you've got the 2-year-old, you're carrying that 2-year-old, you're carrying that, 4-year-old who should be walking, and you're, of course, mothering and holding them. And so all of that impacts the pelvic floor and can cause further injury to those tissues and nerves, etc. And later in life, you can see even in higher risk of incontinence. But often that injury occurs in childbirth. There are other reasons for incontinence, sort of people who have neurologic disorders, multiple sclerosis, things like that, that maybe don't have a 100% relationship to childbirth, but for the most part, childbirth does play a significant role.
Hey, well, thank you. And interesting to hear how those effects can come later in life. So thank you for talking through that with us. All right, Dr. Eccles, we will turn to you now. If you could talk a little bit about the benefits of pelvic floor therapy.
So physical therapy, pelvic floor therapy, is a very individualized program that treats a multitude of symptoms related to the bladder, the bowels, generalized pelvic pain, the vagina, pain with intercourse, even prolapse, incontinence, much, much more. And you have to realize that all of these things, the pelvis is not just isolated. It's connected to the back. There's nerves coming from the back. And also even some patients who have pelvic pain can actually manifest with pain down knees, down in the feet, up in the neck, etc. And so there are 5 functions of the pelvic floor. 1 is sphincter control to keep things in. 2 is support. 3 is sexual function. 4 is stabilization, and 5 is like a sump pump. So it's pumping out either stool or urine. Physical therapy is, recommended for treating pelvic floor dysfunction as a first line. It's low risk, minimally invasive, and it can help with leakage, incontinence, frequency, urgency, pain, difficulty starting or stopping urine, even with constipation, etc. So what do you expect, when you come to the physical therapist, and, hopefully another webinar will be able to isolate that, but you have the problem. So you need to let them know exactly what's going on. And they talk to you, they communicate with you, educate, they take measurements. They want to gather as much information as possible to be able to make that decision and help come up with a treatment plan. So, maybe the external component would be posture, Internal component would be muscles. The key is basically to control the pelvic floor. So it's not just strength, it's control. You can even learn how to relax as well during physical therapy. So keep that in mind. And also remember that it's not just the floor. You have mind control. You have nerves that go from the pelvis up through the brain, and you have the center up there that controls and has a voluntary. So physical therapy also helps that as well.
Okay. And how long do you recommend someone sticks with pelvic floor therapy so they can see results?
So that's a loaded question. As far as exercises, you get taught exercises, you get taught control forever, basically, as long as you can. But, as far as learning how to do them, really the best is to stick with it for about 12 weeks, although a lot of times insurance companies kind of put the kibosh on that. And so as long as you get what's happening and how to develop control, at least 4 weeks of exercises. If you can do more, even 12 weeks would be beneficial. But then after that, you need to continue. It's just, I call the pelvic floor physical therapist personal trainers of the vagina. You go get a personal trainer, you go to the gym, you can't stop going to the gym. You finish with a personal trainer, but you have to continue. And so that's the key.
Okay, thank you. I like that, personal trainer. That's good. All right, Dr. Smith, we'll continue with you. A question still on the lines of pelvic floor therapy, wondering if that can help with urge incontinence.
Yes, so as to kind of echo what Dr. Eccles just stated, pelvic floor physical therapy is vital in treating all aspects of pelvic floor dysfunction. We have guidelines that help guide us to treating things like overactive bladder and urgency urinary incontinence as well. And our first line treatments are pelvic floor exercises and working with the pelvic floor physical therapist. So very vital. I try to prepare my patients that when they go meet with the pelvic floor physical therapist, these are physical therapists who have specialized training in pelvic floor anatomy and pelvic floor disorders. When they meet you, they will do kind of a head to toe assessment. And then when the patient's ready, there will also possibly be an internal exam as well. So they can help to identify any associated condition. So I do tell my patients to kind of a little bit of what to expect. Now, with regards to what a pelvic floor physical therapist can do with urge incontinence, they will meet with you, like I said, identify associated conditions. They'll go over your pelvic floor coordination, your bladder habits, as well as dietary, what your diet is like, your fluid intake, and then also maybe do an assessment of your quality of life and how bothersome are the symptoms to you. That's all important information for them to know what to do. So the pelvic floor physical therapist can also give guidance on identifying your pelvic floor muscles, because we tell women all the time, just do pelvic floor exercises, do Kegel exercises. But oftentimes women don't know how to do those or how to isolate those muscles. They will sometimes use, in addition, other techniques such as electrical stimulation or biofeedback to help kind of train those muscles and identify them. But really, where pelvic floor muscle exercises, pelvic floor physical therapy can be very helpful with urgency incontinence is to teach you how to suppress those urges by using those pelvic floor muscles. And they can be kind of a guard against leakage. So pelvic floor physical therapy, I understand we have busy lifestyles, and sometimes it can be a challenge to get to a pelvic floor physical therapist for 4, 6, 8, 12 or more sessions. And when patients tell me that, even before I send them, I was like, hey, just go and at least get the assessment. That can oftentimes be very, very helpful. And Jefferson and Einstein have excellent pelvic floor physical therapists. And I do echo Dr. Eccles' sentiment that I think that should be a webinar in and of itself.
Definitely another webinar idea. Great. Okay, well, thank you so much for talking us through that. And I know earlier we mentioned about control and relaxation. So along those lines, Dr. Ross, can you talk a little bit about pelvic floor muscle relaxation? So what does that entail and how does it benefit the pelvic floor?
Yes, so this does piggyback on what Dr. Smith so excellently stated about pelvic floor physical therapy and what Dr. Eccles talked about. It has to do with relaxation of the pelvic floor, but overall control of the pelvic floor. So for someone who's experiencing incontinence or prolapse, we can teach them how to do Kegel exercises, and physical therapy can also walk them through Kegel exercises. That is an exercise of the muscles of the pelvic floor. And you can find those muscles. If you think about it, if you're ever rushing to the bathroom trying not to wet, then you're squeezing muscles to hold in that urine. Or when you're in a social situation, you're trying to avoid passing gas, we're squeezing those muscles to try to stop passing gas. So it's those muscles that we're thinking about when we talk about pelvic floor Kegels and pelvic floor relaxation. And if you're in the office with your provider, we in our initial exams can always place sort of one finger vaginally and have you squeeze that so we can tell if you're actually able to identify those muscles. And we know they're the right muscles because you're not moving your abdomen, you're not moving your buttocks, you're really just moving those inner muscles. When you find those muscles, either just by knowing them, because it seems like many people say, oh, I've tried Kegels and they don't work. So many of us do know how to do them, but your provider can also help you, and a physical therapist. But when you find those muscles, then you practice squeeze of those muscles, and you hold in for 8 to 10 seconds, and then you release. And you do that approximately 10 to 12 times. And you repeat that 2 to 3 times a day. And probably after 3 months or so, you might notice a difference. So initially, when you start to squeeze, you might only be able to hold for 1 or 2 seconds, but then you can gradually build that up. And especially for people who have not horrific incontinence or a huge prolapse, it really can make a difference. Sometimes we're talking about incontinence in my question, but sometimes if you have just a small prolapse and it falls out when you're active or when you're busy or lifting things, if you do these exercises, they can help you to hold things up. And if you sort of aren't ready for surgical repair, it can help lengthen that time before surgery and be just very helpful in changing your quality of life. We can do that strengthening of the muscles, but there are other times when you have sort of pain issues or even more pelvic floor dysfunction or issues going on besides the incontinence or prolapse. At that point, we want to, there's also relaxation techniques of the pelvic floor. And if you have those more complex issues, or if you are not sure how to do the Kegels, or if more pain or the other pelvic floor issues are your and let me just say that again, if more incontinence and pain are both there together, then you probably want to go to a physical therapist and they can help guide you and exactly how to do that. And even as Dr. Smith was saying, even if you can't go all of that time, it really merits seeing them because they're very comprehensive in their care. They'll take into account your incontinence, your prolapse, if you have pain. They'll take into account all constipation, so all things related to the pelvic floor, and they can really help you find the ideal. And if you even can go for 1 or 2 sessions, they can teach you things that you need to know. And at Jefferson, we're so fortunate to have excellent therapists.
Absolutely. Okay. Well, thank you so much. Moving along to our next question here, Dr. Quesada, there were a lot of questions about this topic in particular. Question for you, is botulinum toxin A, or also known as Botox, a viable non-surgical option? And what are the pros and cons?
Yes, so Botox or botulinum toxin is a neurotoxin that is available. There's about 7 serotypes, and clinically we use serotypes A and B. Botox is a viable non-surgical option for the management of overactive bladder. So overactive bladder is defined by the ICS as urgency, which is usually accompanied by frequency, and nocturia, which is getting up more than once at night, with and without incontinence. I always tell my patients, not all incontinence are created equal, meaning every time you leak, there's not going to be one management that's going to sort of fix all types of incontinence. Some patients, and the majority of patients that I see, have 2 types of incontinence. One is an overactive bladder, which I just discussed, and the other one's a type of incontinence that occurs with activity, which is called stress incontinence. And that occurs, as we have already discussed, with activity, coughing, sneezing, and laughing. Botox is or has been FDA approved for the management of overactive bladder. And it is a viable non-surgical option. We do it, it's a minimally invasive way. So pros, it's minimally invasive, it's done directly in the office or as a short outpatient procedure. The medication is placed directly into the muscle of the bladder, and it allows the bladder to increase capacity, thereby improving the urges, the frequency, and the incontinence episodes that occur. The other pro is that it does replace oral medication. So instead of taking a daily oral medication, you can essentially have this procedure done once, maybe twice a year. And it does last for about 6 to 9 months. And that leads me into the cons. It is something that you may have to have repeatedly done because it does wear off. So as I stated before, you may have it done once a year, maybe twice a year. And some of the side effects associated with Botox, in about 18% of patients, you may get a urinary tract infection. And if you do, we manage it with an antibiotic and the UTI goes away. And the unwanted side effect of Botox is that in about 7% of patients, you may have voiding dysfunction. And the extreme version of that is having urinary retention, the inability of emptying your bladder, which would require the patient to take a catheter and empty their catheter 3 to 4 times a day, should that occur. Again, the risk of that is very low. It's about 7%. That risk is twice as high in diabetics. So I do counsel my patients on the fact that, if this is not even an option for you, or if you're not able to catheterize or have a caregiver catheterize you, should that happen, then Botox is not an option. That said, I have plenty of patients that do Botox. They're very happy with it, and they do come back to get a repeat sort of session done.
Okay, well, thank you. And thanks again, knowing that question we received a lot of, so we appreciate you walking us through that.
My pleasure.
All right, Dr. Eccles, we will turn to you now for our next question. Before we dive in, I just want to say thank you so much for everyone submitting your live questions. I see that we're getting a lot in the chat, so we appreciate it. And we will turn to our live questions in just a bit. But for now, a question for you, Dr. Eccles. Is mesh safe for repairing pelvic prolapses? And are there pros and cons to mesh?
So the short answer is, in the right hands and in the right patient, it is. Now, the long answer essentially is, in the past, some who have opted for transvaginal mesh surgery to fix their problem have encountered some complications, including bleeding, pelvic pain, pain with intercourse, even erosion or exposure of the mesh into the vaginal wall. The FDA first investigated all of this publicly in 2011, and then in 2018. And then the ruling in 2019, they actually effectively discontinued this procedure that sometimes did not result in safe or positive outcomes. Now, in October 2022, they actually in 2011, they started to require a post-market surveillance study for the companies that wanted to continue to use mesh. And in 2022, actually, they determined that the benefits don't outweigh the risks. And so in the right hands, it may work, but there's still to this day no transvaginal mesh available. And so all the mesh for pelvic organ prolapse, and this is for pelvic organ prolapse, not incontinence. So we're talking about prolapse now. And so the mesh that is used doing what I'd spoken about earlier is the sacrocolpopexy or sacrohysteropexy, and where mesh is used to suspend the vaginal vault to a ligament next to your backbone and the sacrum. So basically, women who've had transvaginal mesh, they should continue with their annual checkups and, other routine checkups. If there's no issues, then there's no need to take additional action. And really, they should notify, the healthcare providers if they have any complications or symptoms, including vaginal bleeding or persistent discharge, even painful sex. And just let the healthcare professional know that they've had mesh, especially if they're going to have another surgery. Now, the pros of mesh are, it results in less recurrent prolapse. That's been proven. Now, it hasn't been shown to reduce the rate of repeat surgery, but it has resulted in less recurrent prolapse. And mesh placed abdominally or robotically, laparoscopically for pelvic organ prolapse, like in a sacrocolpopexy, may result in lower rates of mesh complications as compared to transvaginal mesh placement. So, and then mesh and midurethral slings have been studied, just on a side note, because when you talk about mesh, every time you hear mesh, it's this stigma. Mesh and slings for stress urinary incontinence is actually very successful, a low complication risk. Now, the cons, of course, is, use of surgical mesh through the vagina is linked to higher rates of mesh-related problems, such as poking through the vaginal wall, pelvic pain during sex, exposure, discharge, mild discomfort, up to debilitating pain. And, there's up to a 20% risk of shrinkage. And so that can cause pain too. So there may be a prickling feeling. But again, the candidate needed to be picked correctly. So if you have somebody who has severe vaginal atrophy or poor vaginal health, that's not a great mesh candidate. Somebody with pelvic pain, not a great mesh candidate. And so that's kind of the history and the sequela of mesh. So it's not a bad thing. It's just that it has to be the right thing for you.
Okay, well, thank you. And we appreciate you walking us through that. All right, we will turn to our next question. Dr. Smith, this one's for you. Another few questions that we've been receiving a lot of, and this is about what exercises can people do and what can be done at home to help strengthen the pelvic floor?
Yes. So fortunately, Dr. Ross was able to explain how to identify those pelvic floor muscles, which can be tough. It's not intuitive to just know how to do those exercises for a lot of women. So during your initial exam with your urogynecologist, we do a very detailed pelvic exam. We do assess pelvic floor tone, muscle strength, and the ability to isolate those muscles. And I try to see how long a patient can perform that pelvic floor muscle exercise, because that helps me to kind of direct them to their therapy. And when we're wrapping up the visit and I'm explaining how to do pelvic floor muscle exercises, I tell patients to think of it like a prescription or else they forget. So just like Dr. Ross said, depending on how long they're able to hold those pelvic floor muscles in the initial visit, I'll tell them to squeeze for however many seconds, then relax for however many seconds, repeat that 10 times in a row, 3 times a day, for 6 weeks. So, and then report back to me. So it's kind of like a prescription. So that way they're able to kind of remember, okay, I have to do this. And it can take time for patients to start to feel effects, but there's no downsides to doing pelvic floor exercises, and you can pretty much do them anywhere anyone needs to know. Now, how we can use them for some of our pelvic floor disorders in particular, such as urge incontinence and that bladder control. We think of urgency suppression. So when that urge is coming, you feel it coming, you stop what you're doing, you freeze, and you do quick bursts of those pelvic floor muscle exercises, 3 to 4 to maybe 5 times quickly in a row. And that can sometimes dissipate the urge. And then you realize, hey, I don't actually have to go to the bathroom. And that over time, that can help kind of, calm the urges. In addition, that can be combined with what's called bladder retraining. I tell my patients it's like adult potty training, where initially you're going to the bathroom on a schedule, and your urogynecologist will work with you to kind of know where to as a stopping point, because maybe you've completed a bladder diary, have done very detailed history. And then each week you're going to extend that interval. So for example, if you're going to the bathroom every 2 hours initially, the next week you're going to increase that interval to maybe 2 hours and 15 minutes. Now, what if that urge comes between then? That's when you use those urgency suppression exercises that you learned, and you do those urge suppression exercises, and that can get you to the 2 hour and 15 mark. And then you keep extending that interval till you're going to the bathroom maybe every 3 to 4 hours, which is pretty normal for adults. So that's how pelvic floor exercises can be used to not only strengthen the pelvic floor, but also how to control urges and deal with urgency incontinence.
Okay, very helpful. And I like the way of thinking of it as a prescription. So thank you for that. Okay, well, I know that we are receiving a ton of live questions. So I think if we're ready for it, we'll go ahead and answer a few of our live questions that we're getting from the audience. So with that, I will start us off, and whoever wants to jump in and answer, feel free to do so. But question number one from the audience: if a woman rides a bike frequently for 35 to 40 miles at a time, can that affect the pelvic floor and cause incontinence? So whoever wants to answer here.
I'm gonna take a stab at it. So the short answer is no, but if you ride a bike for 30 to 45 minutes, and for how long? What did you
Yep, 35 to 40 miles at a time.
Yeah,
Yep.
for a long time. And so you're sitting. If you're sitting and you're not taking bike breaks, you're actually impinging on what's called the pudendal nerve. Your pudendal nerve contributes to some issues of the bladder. And if you develop an issue of the pudendal nerve, which can be, I mean, if you're riding for a long time and you're sitting, you could put that nerve on stretch, then technically you can develop some urgency, you can develop some bladder issues. And so that's when you need to be evaluated. And that's also where pelvic floor therapy does help. The other thing is, if you're going to ride for 30 to 40 miles, you may want to take what's called booty breaks, because I ride myself, and you stand up, you ride, sit down, stand up, and to take a break off of that.
Okay. Well, thank you. We appreciate it. All right. Next live question here. And again, whoever wants to jump in, feel free to do so. This person is wondering, is it possible if women may need a repeat surgery for a prolapse bladder after a certain amount of time, such as 20 years?
So that is possible. And it really depends on the type of operation or the indications of the previous prolapse repair. And I actually tell patients, I think of pelvic organ prolapse as a chronic condition, because this is weakening of your tissues that are supporting your pelvic organs. And it's almost like a hernia. It's kind of like a hernia of the vagina, essentially. So this can reoccur. In particular, what we've found is, depending on the type of repair, so if you've had a repair of the front wall of the vagina or the top wall of the vagina, in the compartment that may not have had a repair, you can actually develop one later in life. So that's sometimes where some of the recurrence of the bulge comes from, is the compartment of the vagina that may not have been corrected in the beginning can become a problem later in life. So there's many options when it comes to a repair on someone who's had a previous pelvic organ prolapse surgery, who is looking to have surgeries. And in general, there can be vaginal operations as well as the abdominal operations, such as the sacrocolpopexy, that can be done. And in general, it'd be taken on a case-by-case basis, taking into account comorbidities, the previous operation, and things like that. But in general, we can absolutely reoperate on pelvic organ prolapse, and it can certainly happen depending on, the situation.
Okay, thank you. And Dr. Ross, I saw you're going to jump in there as well. Anything you'd like to add there? I know Dr. Smith had a very thorough answer, so thank you there.
Perhaps just simply, as we've discussed before, let's say that prolapse is happening and you're aging and you're concerned about having surgery at your age, or you have mitigating health issues. There are always procedures that can cause closure of the vagina that are very low risk, and they are designed for people who that bulge is affecting their functionality, being able to be active, being able to be hygienic, etc. And those are excellent surgeries to consider. And with those surgeries, only the vagina is closed. You're able to urinate and have bowel movements normally. So that's something. So any level of recurrent prolapse can be repaired.
Okay. Well, thank you both. All right. Our next live question. Let's see here. Which tests are completed to evaluate both incontinence and prolapse? And would surgery be able to fix both at once?
I can take that. So a good history and physical exam on our initial visit is going to provide us with the majority of the information that we will need. Usually in our office visit, we do evaluate for the ability of the bladder to empty and whether or not the patient is able to leak during the time of the exam. So if I'm able to reproduce the leakage and the patient is uncomplicated, meaning she's never had any previous surgeries and sort of no red flags, there's not much that we would do except probably get a urinalysis and do a quick ultrasound or a catheterization to make sure that we obtain a post-void residual, as well as do our quantification of their pelvic organ prolapse to determine their stage. Again, these are for uncomplicated patients. For patients that are more complex, who have had previous surgeries, or in patients that have urinary incontinence symptoms and we are unable to reproduce them, if they have any neurologic condition, if they have obstructive symptoms, if they feel like they're rocking back and forth to empty their bladder, then we do complement our physical exam with another test, which is called a urodynamic study. Our urodynamic study is a study that we use to essentially obtain the sensation of the bladder, the stability, the capacity, the competence of the bladder neck, and it gives us more of a comprehensive understanding of the bladder function. And then at that point in time, we can determine the bladder capacity, determine whether or not this patient has an overactive bladder, whether she has stress incontinence, or whether she has both. And then we can formulate a plan as to what surgical options would be available to her at the time of her surgery. And then the second question is, can we address both pelvic organ prolapse and incontinence? As I stated before, incontinence is not all incontinence is created equal. So we can address essentially pelvic organ prolapse and stress incontinence the majority of the time in one surgery, with 2 surgical procedures that sort of can be done at the same time. With an overactive bladder, I tend to take the respect the urge sort of management, where I manage that medically first before addressing the stress incontinence. So some patients may undergo surgery for pelvic organ prolapse and their stress incontinence, and then we would manage them post-op or pre-op, as I usually tend to manage them pre-op with alternative options such as conservative options, pelvic floor physical therapy, or medications orally, or Botox, or the sacral neuromodulation.
Okay, well, thank you so much. All right, next question. And thank you all for submitting these questions. We appreciate such an engaging discussion. But a question here about, is there an age at which therapy is no longer helpful? So any particular age that therapy is no longer helpful? Whoever wants to talk about that.
I'm going to say no.
Okay. Go ahead.
If you can't essentially follow, I hate to say follow directions, but if you don't understand what's happening and you're not able to kind of do the exercises. I mean, even a little bit of therapy will help. Even a little bit of mind, bladder control will help. And that is included in therapy as well. So I'm going to say no, but it may vary. And so, you know, these training programs and physical therapy programs are individualized for that reason.
Okay, thank you. And Dr. Quesada, was there anything you'd like to add there?
Sorry. Yeah, so yes, I would agree with Dr. Eccles. There's actually been some recent data that talks about pelvic floor physical therapy in the elderly. And sometimes the isolation of those pelvic floor muscles tends to be less in the older population. So therefore, because they're unable to isolate some of those pelvic floor muscles, they don't get the benefit. But they do see some improvement in pelvic floor, you know, sort of movement but ultimately, you know, they may have some weakening as a result of just normal aging process. And so they may not do as well as sort of a younger patient.
Okay.
If I can also add as well, there can certainly be benefits to managing pelvic floor disorders, especially urinary incontinence. In the elderly, it can oftentimes be a reason why an elderly woman may end up changing her living situation to be, you know, to maybe assisted living or a nursing home. Is because of urinary issues. So having an assessment to see what she is a candidate for. Maybe surgery is not an option. Sometimes incontinence pessaries can work. Adjustment of medications, improving associated medical comorbidities. You know, if they can manage, you know, maybe a small procedure or something like that, that can really help to change one's living condition. So there's really no age where we would withhold treatment. It just, you know, there's many different options and we just see what the person is available, you know, candidate for.
All right. Well, thank you all for that.
Wait, and to add one more thing,
Yeah.
and to add to this, don't forget, I mean, sometimes even just a bedside commode, because they just can't get to the bathroom on time, or even having the bathroom closer. That's all part of therapy, especially for the elderly.
Okay. Thank you. Certainly an engaging discussion here. So appreciate that question. Okay, the next question, we're going to talk a little bit about painful bladder syndrome. And this person is wondering how to approach treatment for that.
I can start by taking a stab at this. So painful bladder syndrome, also known as interstitial cystitis, is a what we call a diagnosis of exclusion. So kind of bare bones definition that I tell my patients who I'm considering a diagnosis of that condition is they have to have a urinary symptom, so frequency, urgency, incontinence, as well as an uncomfortable feeling kind of in the lower abdomen pelvic region of at least 6 weeks. And we've ruled out other conditions that can cause it, such as a urinary tract infection. You know, if they have a smoking history or something like that, making sure this isn't a bladder cancer, things like that. And we don't exactly know why it happens, but we do have theories which kind of helps dictate treatment. And we do fortunately have guidelines from the American Urological Association that kind of help with management. And it's a stepwise approach. So we start with very conservative things, moving on to at the extreme end, removal of the bladder and urinary diversion. So during the initial evaluation, and assessment, if we're considering that diagnosis or making that diagnosis, it's really important to have a good foundation with the initial steps. So first line treatments is I explain to patients what is normal bladder function. I talk to them about potentially what the different causes that we think cause it. And then we work on diet. We identify, you know, I have patients do review and we go over dietary changes that they can make to avoid bladder irritants, in particular acidic foods, spicy foods, carbonated beverages. I also talk to them about stress management, easier said than done, self-care, and working with a pelvic floor physical therapist. Those are all things that are good foundations before moving on to things like medications, endoscopic procedures like a cystoscopy, other procedures and medications as well. And it's important to take a stepwise approach because we want to identify things that work and not do things that don't work, because it can sometimes get a little bit complicated. And our patients who often have interstitial cystitis, bladder pain syndrome, have many allergies. So we don't want to do anything that's going to trigger that. They have associated conditions as well, such as migraines, irritable bowel syndrome, endometriosis, things like that. So it can be kind of complex, but really the fundamental things, self-care, stress management, getting a good handle on diet, and working on pelvic floor dysfunction, usually with a pelvic floor physical therapist to get started.
Okay, thank you. And no, we're just over the hour here, so we'll answer 1 to 2 more live questions and then we'll wrap it up. Okay, so just another question here, a live question that we received, an interesting question. Why may you feel pain in other areas of your body with prolapse, such as in your knees?
I think I can take that. So when you have an imbalance in your body, you can feel it in other areas, and especially, when you have prolapse, sometimes you walk differently, your posture changes. And when your posture changes, then there's center of gravity changes, weight differentials change, and you can manifest with even up by headaches. You can manifest with back pain. You can manifest with ankle pain, knee pain, and that's the reason.
Okay.
And so physical therapy is definitely something to consider, even if it's just adjunctive to a surgical procedure.
The recurring theme of the night, definitely physical therapy. So, all right. Our last live question, and then I have one last question for myself. But the last live question for the evening: how many times a day is considered normal to urinate? Does this number increase if you drink water throughout the day? So is there a normal number of times to urinate throughout the day?
I think I can take that. So I think everybody's normal is different. If you really look at the data, some of the data says that 7 voids per day is considered quote unquote normal. That said, what we manage is a quality of life issue. So if your normal happens to be 8 or 9 or 10 and it's not bothersome to you, I think that when there's a change from what your baseline is, then that's when we start talking about, okay, there's an increase, right, in frequency, or if there's urgency that develops. And yes, fluid intake does, affect the amount of times that you go to the bathroom. So whether it's water, but of course, all of the other bladder irritants that Dr. Smith was speaking about, caffeinated beverages, carbonated beverages, chocolates, alcohol. So things like that also help or contribute to frequency and urgency as well.
Okay, well, thank you. And
real quick though, the one thing, and Dr. Casada said it so eloquently, is you don't want to be dehydrated either, because that actually affects your bladder and can increase urgency frequency as well. So you really want to make sure that you're well hydrated. It's the same concept of, for pregnancy, those women who come in labor and it's false labor, they actually hydrate them. And when they hydrate them, it gets better. And so it's the same concept as far as the bladder is concerned too.
Definitely important to keep in mind there. So thank you. All right. Well, that is our last live question for the evening. So thank you to everyone who submitted such great questions. I know it was a wonderful discussion tonight. But for our final question for myself, would love to know, what are your goals for everyone listening in on this webinar? So what do you want our viewers to take away from tonight? And Dr. Eccles, will go ahead and start with you.
I'm going to say, know your vagina and your pelvic floor. Don't be embarrassed to say something is wrong, something is going on. Ask the questions. And if you don't know, even, I mean, be careful with Google MD, because sometimes it could be incorrect or it could embellish some things incorrectly, but really, really, I mean, it's your body, it's a quality of life. You deserve to have a great quality of life. Talk to your physician, your provider, find out what's going on, and there is help out there.
Absolutely. Thank you. All right, Dr. Smith, any takeaways that you'd like to share this evening?
Yes, so pelvic floor disorders can be very common. So a lot of times women think that this is, oh, normal part of aging. Although they're common, it's not normal, and there can be options. In addition, these pelvic floor disorders, we talked a little bit about them kind of, individually, but they oftentimes go together, and you may require multiple treatments in combination and a little bit of trial and error to kind of get you to where where you need to be. So don't get discouraged. There are many options, and just sometimes a little bit of patience to kind of, see where you settle in and what options work for you.
Okay, thank you. And Dr. Ross?
And sort of to tag on to what both of them, Dr. Eccles and Smith, said, these issues are extremely important. If you think about it, we have a whole entire specialty of female pelvic medicine, reconstructive surgery, and urogynecology to address these issues. And I feel that sort of we've shifted in life where there are so many baby boomers that are young, healthy, and active. A 60-year-old might be like a 50 or 40-year-old. So we all want to be able to function and have a good quality of life. So although some of these issues are not life-threatening, they're certainly such life impacting, and it's very important to address them. And when we talked at the beginning, all of these things are interrelated. The incontinence and prolapse can include fecal incontinence. It can, which is stool leakage. It can include pain and sexual pain, and there are so many issues that we as a team address, and that's the four of us: Dr. Quezada, Dr. Smith, and Dr. Eccles, and myself. We all work together. If we feel that one has more of an expertise in an area, we like to refer just so that we can get your needs met. So we again are privileged to care for you, and these conditions are very important.
Thank you so much. Okay, and finally, Dr. Quezada, any final lasting remarks that you would like to share?
So I would just like to air what everybody's been saying. I think collectively we all manage a global sort of pelvic floor dysfunction. We all manage quality of life that affect women, and we are all women. So one of the things that some of my patients come in to see me is, because I'm a woman, because I understand some of the issues that they are dealing with, so we are here to help. We're located throughout, Philadelphia, and the northern area, the Montgomery area. And like Dr. Ross just said, we do have a multidisciplinary approach to management of the global pelvic floor dysfunction. So we work together and with other subspecialties to sort of, create a care plan for the patients individualized to each.
Okay. Well, thank you again, Dr. Eccles, Dr. Smith, Dr. Ross, and Dr. Quezada for your time this evening. A lot of great information was shared. I know I learned a ton about pelvic floor and incontinence. And thank you all so much for attending and submitting your questions. We will be posting an event survey, so you can let us know your thoughts. Was this helpful? Are there any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. And if you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. A recording of this event will also be sent to you so you can rewatch. And if you would like to view other wellness webinar series events, please visit our Jefferson Health YouTube channel at youtube.com/Jefferson Hospital. We have everything from back and neck pain to robotic surgery to planning for pregnancy and much more. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.